all implementing family planning programs and how to introduce solutions sustainably and at scale. This webinar is an official Transform Health's the Dicta Health Week event. And to introduce the organizers, the Population Reference Bureau's PACE project, which is a USAID-funded project that works with different stakeholders to foster family planning and reproductive health in order to achieve the Sustainable Development Goals. The Medical Concierge Group, the Dicta Health company that currently hosts the Dicta Health Compendium. Maternal, Infant and Health Consulting, which is a women-owned consulting firm that leverages public health to advocate for research, that advocates for public health through research. And Knowledge Success, a USAID-funded project that basically looks at knowledge management for family planning and reproductive health. Before we go ahead with our event webinar, I would like to introduce some housekeeping points that I want us to take note of, such that we all are at the same page. The first one is that there will be simultaneous French interpretation for this event. And to access that, you simply go down to your page that you have opened on your browser and click translation icon at the bottom to select your preferred language. Two is that in case you have any questions, feel free to always engage in the chat feature, where we shall do our best to verbally direct them to our speakers during the QA section, and all our presenters will be able to address them. Please submit all those questions on an ongoing basis in the chat feature. Do not be shy. Feel free to engage as much as possible, such that we have a very fruitful live engagement. This webinar is being recorded, and the presentations will be shared in both English and French, by a follow-up email to those ones who will have attended, and the host and the event will also, so the recordings will also be shared online or hosted online. At this point, I would want us to go ahead and listen in to the Dicta Health Week video. Thank you.
In 2015, world leaders committed to providing quality health services to everyone by 2030. We have less than 10 years to reach the goal of universal health coverage, and yet over half the world still lacks access to essential primary health care. As a consequence, 930 million people are at risk of falling into poverty due to out-of-pocket spending on their health needs. Digital technologies hold the potential of accelerating progress to health for all. Effectively deployed, digital technologies can strengthen health systems, support individuals to better manage their own health, and enhance the availability, accessibility, affordability, and quality of health services. Digital Health Week is a global moment to champion the role of digital health in universal health coverage. During Digital Health Week, organizations around the world are coming together to host events, make public commitments, and shine a light on the successes and challenges of digital health and UHC in their context. During Digital Health Week, civil society, private companies, government health ministries, and interested individuals are discussing the challenges and opportunities for digital health in their countries and regions. How far has digital health come? What barriers must still be overcome?
Our work on improving HIV rights and sexual and reproductive health and rights in Kenya, it is no longer possible to ignore the potential that digital health holds in improving access to health services and realizing the right to health.
YACMI, or the Indonesian Public Health Association, commits to working for the goal of universal health coverage through our 35,000 members. The time to champion digital technology is achieving health for all is now, and we will be hosting the 7th annual Public Health Scientific Conference during digital health and bring together leaders from across Indonesia and promote digital health.
As we build a digitally enabled future, it's imperative that the voices of young people are not left out of the design, planning, and implementation of these interventions. Digital Health Week is an exciting opportunity for young people to showcase their digital health solutions as we will be doing through the Humans of Digital Health campaign by Yes4H.
The first Global Digital Health Week is being coordinated by Transform Health. We are a coalition of organizations committed to championing the role of digital technology and data to achieve universal health coverage by 2030.
We want to see the transformation of health systems to ensure that everyone has access to equitable, affordable, and quality healthcare by harnessing the potential of digital technologies whilst ensuring no one is left behind. This requires stronger political will, a clear health data governance framework grounded in human rights and equity, and increased and coordinated investment towards digital health.
So join us during Digital Health Week to champion health for all in the digital age. Hold discussions, make commitments, and amplify the role of digital health on your organization's website and on social media.
Right. I welcome you all back from that very insightful and interesting video. So before we begin, I want to bring us to the same page as regards to the agenda for the webinar. We shall have presentations of around 12 to 15 minutes from 4 organizations who we have profiled that have implemented digital solutions at scale. And these organizations will have representatives presenting on their behalf. After the organization presentations, we shall have a QA, question and answer session at the end, which will be led by Maternal and Infant Health Consulting. And this QA session will lead into the conclusion section of the webinar. However, as part of the content that we shall share, we shall have a presentation, an overview of the compendium, the Dicta Health compendium. This Dicta Health compendium, as we shall see, will also feature key insights on the 7 sustainable, more like, should I say, important points that we should take note in order to develop sustainable and scalable digital solutions, which is part of the blog post that the webinar put out. And also, we shall do a general summary at the end of the different projects that we'll have profiled. Without further ado, I will go ahead to start off the presentation with a general overview of the Dicta Health compendium. As I dare introduce myself, I'm by the names of Dr. Louis Kamnege, and I'll be taking you through the Dicta Health compendium. So the Dicta Health compendium is an online digital tool that currently houses over 16 new and previous 24 digital health solutions in family planning. It's accessible online via any web browser, Mozilla, Firefox, and the like Safari, by just clicking onto the URL that has been shared in the chat. And this compendium houses different innovations that are leveraging digital solutions to address different gaps in family planning and sexual and reproductive health in the sub-Saharan Africa and also in Asia, so more like in the global south. The aim of the Dicta Health compendium is basically to advance the adoption of digital health technology in family planning by identifying promising approaches and sharing lessons learned in order to increase efficiency and enhance family planning services and access in the global south. Yes, this compendium is mainly targeting different stakeholders or players in the field of family planning, including policymakers, the implementers, and also the designers of these digital health solutions. And to the policymakers, the value of the compendium is basically to understand the solutions that have been designed and implemented and deployed within their geographical areas. This can help them to understand what has worked and what can be scaled in order to achieve a national coverage. To the implementers, learning from what has succeeded in different geographies and being able to be piloted or mirrored in specific geographical locations or in other geographical locations can help to share experiences can help to adopt new technologies that can be used in different settings to achieve the Sustainable Development Goals, especially Sustainable Development Goal 3. And to the designers of the innovations, the compendium helps to borrow solutions from what is already existing, and not to reinvent the wheel or to start from scratch. The key, the key information that we want you to get away from the Digital Health Compendium is that currently we have over 52 cases, as you'll see in the link that has been shared, and 14 have been added this week. It covers innovations in low and middle income countries, and especially in the global south. The interventions have been detailed to include not just the name of the innovation or the implementing partner, but also details as regards to how the innovation was implemented, the exact location or countries where these innovations have been implemented, the lessons learned in terms of what worked, what did not work, the monitoring and evaluation data, especially in terms of the impact, the reach, system integrations that were achieved by the different innovations, and also learnings shared that can be reciprocated in other settings. Yes. Next slide, please. So, what do we learn from the cases that were shared in the compendium? That four of them have been profiled, and presenters will be taking us through. The cases that have been profiled and are going to be part of today's discussion have been able to achieve sustainability and scale. And in order to achieve sustainability and scale, a review of the submitted cases showed 7 learnings that we need to put in mind or in context if sustainability and scale is to be achieved for all digital health solutions deployed in family planning. The first one is ministry involvement. Depending on the country of context, ministry involvement, the ministry or the line ministry in charge could be Minister of Health, Minister of ICT, or Minister of Innovation, depending on the country where your innovation is being implemented. It's very important because the ministry plays a lot in terms of approvals of these innovations, and therefore designing along with the ministry right from the ideation stage to full deployment is very critical for local ownership and achieving scale, but also at the time, but also in the event that certain countries in-country regulation warrants local hosting of these innovations, especially when it comes to data and systems. It's very important to involve the ministry right from the start because it increases local ownership and sustainability. 2 is that innovations should be developed with the revenue generation mindset right from the outset. This is very important because funding is critical for any sustainability of any digital solutions. A case in point is when you're developing digital solutions, you could model them to have a revenue generating arm, the one where, for example, users pay a low cost to access the services through an application, whatever innovation that has been developed, such that that compensates for another demography that may not pay, they don't have the access to the funds that to the fees to access the innovation, and therefore you have more like a cost sharing model. One arm the user pays to compensate for the other arm that say rural demographic population that may not be able to pay, and therefore you're able to generate revenue that helps sustain the solution and be able to scale. Adaptability mainly looks at the ability of the tool to meet different demands at different use cases. It's very important to design tools with the ability to be agile and adaptable to different use cases. For example, designing a tool that at the outset only answers, say, specific health problem or a health area, say Ebola, but then in the due case, a new pandemic called COVID comes up, the solution or the Dicta solution should be able to be adopted and evolve to address the new challenge, which is COVID, rather than saying, let's develop a new tool to address COVID, because that leads into duplication and problems of system integration. So it's very important to develop tools with ability to adapt to any new asks or needs that will come up. Elasticity mainly looks at the ability of the tool to be easily developed, upgraded, adding new features as and when need comes, or be toned down in case there is any need for reducing on the need of the tool. In terms of uptake, like any other tool that whose scalability is going to be measured by how it's taken up. So the more the tool is beneficial to the target audience, the more it will be taken up, and therefore the measure of scale. And lastly, integration. The tools to be developed for family planning should be integrated, should be designed to be integratable to existing public health or public tools that are like the global goods, and therefore designing or deploying family planning tools that are integrated, that can be integrated within existing platforms is very important to ease usage and also increase its adoption. Yes, can go to the next slide. So I would like at this point to introduce the first project that has been profiled, which is Empedigree, and I will be introducing the presenter. The presenter is Eugene Bodu, who is the head corporate affairs at Empedigree, and I will give it up to Eugene to further take us through Empedigree and the discussion. Thank you.
Thank you very much, Doc. Really excited to be here. Thanks for that comprehensive overview. Good morning, good afternoon, good evening to everyone, wherever you're joining the discussion around the world. My name is Eugene Kweku Buadu. I'm head of corporate affairs here at Empedigree, and I shall be making a presentation discussing our work and some very key lessons that we have learned working within the family health space, our contributions to the family health space, and some of the very valuable lessons we've learned, and how we believe they shape the conversations around adaptability, scalability, and sustainability for digital health solutions. With the permission of the moderator, I'll begin my presentation now. If the slide could roll. So Empedigree is a social enterprise that is committed to building technologies, harnessing technologies to empower consumers, individuals, governments around the world to fight counterfeiting. Counterfeiting is a global issue affecting just about every country on the surface of the planet. But it is the third world countries or third world economies that have suffered the most. If you look at the data, countries in Africa, selected areas in Asia, appear to be the worst hit. Just about everything at all is counterfeited, from cologne to wines to clothes to vehicle parts. But it is the trade in medicine, the trade in counterfeit medicine, that has aroused, and for good reason, the greatest alarm over the last decade. The estimates are such that the trade in counterfeiting is really rewarding, and even more worrying is the trend, which suggests that proceeds from counterfeiting are linked to other global crimes, other illicit activities such as terrorism. And if you take Africa, for instance, if you take sub-Saharan Africa, you take a country like Nigeria, somewhere around 2008, 2009, it was estimated that between 40 to 60% of the medicines in circulation were at some point thought to be counterfeited. This was the scenario before our organization got involved. Now, so I talked a little bit about numbers. And sometimes my personal view is that statistics and numbers tend to be impersonal. When we speak about the counterfeit trade being around $700 billion, in some of the estimates as high as $1 trillion, when we speak about medicine in circulation, some 40% of antimalarials, for instance, in circulation being counterfeited, these are just numbers. But behind those numbers are real people. The statistics can be impersonal. But these represent the deaths of human beings across the world. In your shot right now is the image of a famous Nigerian musician who died after being exposed to counterfeit medicines. So we are really dealing with the deaths of millions of people, in a lot of the instances, children and infants around the world. The problem really translates to the taking of lives from amongst us. My next slide, please. Now, the thing about counterfeiting is that their cost of production is extremely low. They produce without regulation. They do not use the right configuration of active ingredients. You can see some of the images that have been captured of counterfeit hotspots that were busted by security agencies. And you can see the very unhygienic circumstances under which they produce. This enables them to essentially sell chaff at close to the same market price that legitimate producers will sell. And hence they make a whole lot of profit. The consumer typically is presented with an original and then, a fake one. If you were sick and you went to a pharmaceutical shop, you have about 2 minutes to decide. And in your shot is, an image of two products. One is counterfeit, one is the original. And even the most trained professionals cannot tell simply by physical examination the one that is original and the one that is fake, because the counterfeit brands are able to very effectively mimic the exterior branding and look of the actual medicines. So there's virtually no way to tell, and all of us consumers are at risk anytime we want to buy medicines or anytime we want to buy a health-dependent, a health-related product. There are also very severe implications of counterfeiting. You talk about the impact on the intellectual property rights. Brands have spent monies to develop products, and then they get undercut by these counterfeiting. You talk about the effect on the economy. These counterfeit brands, most of them are able to evade taxation, and so the revenue that should go into government, that should go into supporting the economy, is completely lost. They also undermine the healthcare delivery process, because if you're a health professional and you are given medicine and the patient is not responding, you get frustrated. And in third world economies, where technology and illiteracy rates are still significant, you would find that the resultant effect is that there is doubt about scientific treatment for various medicines. So the effect of counterfeiting, beyond the loss of life, beyond the impact on the economy, is really, really significant. The next slide. Now, companies responded with all manner of ways. There was the hologram technology, there was the RFID technology, and there were attempts to use the insert, the educational materials that are inserted into the packs to distinguish. All these things were pretty confusing for the average consumer. And in the case of holograms, it turned out that the counterfeiters were producing holograms that were even shinier than the ones that the legitimate manufacturers were producing. So again, the initial attempts were pretty much a failure. Sophisticated technologies such as RFID solutions were also not compatible with the public health budgets of developing countries. Incomes are low, governments are constrained. And so any solution that was going to add significantly to cost was not going to be sustainable in the medium to the long term. Next slide. So I mentioned the bit about the holograms. This is an image that shows the hologram, and then also the RFID technology and how it is not compatible from a cost perspective with public health budgets across the developing world. Next slide. Next slide, please. M-Pedigree solution is simple, that we will place a unique sticker on each product. That sticker will carry a unique serial code. At the point of purchase, the consumer can, using their mobile phone, text that serial code to a toll-free short code. And then within seconds, they will receive information about that specific pack they have bought, whether it is genuine, whether it is not, whether it is, they can consume it, whether the regulatory authorities have endorsed it, and if they have any feedback at all, it will also give them a feedback mechanism via which they can lodge their complaints. Next slide. So as I mentioned, the serial code goes onto the product. The consumer can use their mobile phone, whether it's a smart one or a standard feature one, to simply text the code and within 5 seconds, obtain critical information about the specific pack they have bought and whether it is healthy for consumption or not. Next slide. We have worked in Africa, with governments and regulators to protect a number of medicines. We have done a very important work in the family health space. We've worked with, I'm going to talk about two brands we've worked with in Ghana and Nigeria. In your short, it's a product called Lehrer, which is an emergency contraceptive pill, very popular in the West African markets amongst young people and young women who want to make decisive choices about their reproductive health patterns. And when we started, there was no way to tell whether the one that you've bought is indeed original or fake. And I have spoken to journalists who have told me that they have used emergency contraceptive pills that have failed and that have resulted in pregnancies. So we partnered with the Lehrer brand to protect them and to make it possible for every young person, every lady, every woman buying an emergency contraceptive pill to be able to tell whether the specific one they have bought is original, is safe, has gone through the process of certification, and so, give them the confidence to be able to use it. Next slide, please. So in your shot right there is the Lehrer pack with the scratch label. All the consumer has to do is to simply scratch it, review the code, and text it to 1393. Next slide, please. And then within seconds, within typically 2 to 3 seconds, they receive a message of authentication direct on their handset that the message is indeed that the medicine is genuine, they can use it, and they have any adverse effects at all. These are the mechanisms via which they can reach the manufacturer or via which they can reach the health authorities to log their complaints. Next slide. So the Postinor brand was heavily faked in Nigeria before we went in to work with them. There were many concerns about consumers buying Postinors that were failing, and the brand manufacturers themselves were very, very frustrated. Next slide, please. So they tried some campaigns that did not work, such as social media campaigns, but all of that was not effective because consumers still could not tell. Next slide. Next slide, please. So we began working with them, serializing each pack of Postinor that will be sold. And anytime anybody buys it, they can scratch, they can text, and within seconds, they can get the assurance that they have the actual medicine and not a counterfeit. Next slide. So these were some of the social media feedback that was generated when we launched the product. It was very heavily well received by consumers, and they expressed their satisfaction about now being able to sift out the original personal from the fake one. Next slide. Whilst all that is going on, the brand is also able to gather critical intelligence about the product, the phone numbers, the people texting them, and they can use all of that to refine their marketing and sales strategies, and also to be able to directly communicate with patients or consumers that are buying their products. Next slide. So we've done this across Africa. We are currently operational in about 22 countries in Africa and Asia, and we have a support base in Europe as well. Next slide. And Pedigree was one of the very first companies to go to market with this very unique solution. Next slide, please. Next slide. So I want to spend the remainder of my time, whatever is left of it, to dramatize the commercial model that has proven very sustainable in the markets in which we have worked. So our solution is free for consumers. It is free for the government. The government uses it to police play their regulatory roles very well. But we charge a small levy to industry to enable us to remain operational as a social enterprise. Of course, we are driven by impact. We are driven by the ability to change lives, but we also recognize the need to be self-reliant, and also to be sustainable. And so we came up with this pricing model that targeted industry, that the companies that are going to benefit from the solution, that are going to use it to protect their brands, are going to pay just a little levy, and we are going to run the service free for consumers. We're also going to run it free for government. And that was a very heavy indication of our commitment to the social impact of our work. And I'm very excited to announce that it's proven very sustainable over the last 7 to 8 years, during which we have gone full-scale commercial deployment. And in the first 3 to 4 years of our commercial deployment, there was no upward adjustment in the prices of the medicines that were affected by our technology. And that was the clearest indication to us that industry was able to absorb the cost of the technology without passing it on to consumers who already in these markets have very low incomes. Next slide. So as I mentioned, the strategy has been validated, and we have seen that in all the markets in which we deployed, the prices of the medicines did not increase after the adoption of the technology, reinforcing the idea that we're able to create value, we're able to create social impact, and we're able to do that within existing budgets and not have consumers pay more for the same services. Next slide. And beyond that, the system has also been validated in other areas such as the agricultural and textile sectors as well. So it's proven really robust, and it has proven that it is a healthy template to adopt when it comes to addressing problems, especially problems that can be solved with the digital solutions within the family health space, but then also within the broader area of healthcare delivery in general. Next slide. And for our work, we have gotten some recognition, such as the World Economic Forum. We've gotten awarded by the Skoll Forum as well. And in a nutshell, this is our story as Pedigree, and this is our work and our contribution to the family health space in Africa and other markets around the world. Thank you so much. I look forward to interactions during the question and answer section. Thank you.
Thank you, Gwen, for that very wonderful presentation. We shall have the question answer session at the end. Now, let's go to the next presenter, Bridget Deacon. Bridget is the Managing Director at Shujaz, a two-time Emmy award-winning multimedia platform based in Nairobi, Kenya. Before moving to Kenya in 2006, Bridget worked with BBC in London, specializing in youth television drama. She will be speaking to us about Shujaz Chukruk program. Over to you, Bridget. Thank you.
Hello, everyone. Apologies, I was pressing the wrong button there. My name is Bridget Deacon. Thank you very much for the introduction, and I'm really excited to be able to tell you a little bit about Shujaz Inc. and the programs that we produce. Next slide. I'm just checking, can anyone hear me?
Yes, we can hear you clearly. Thanks.
Great, thank you. We're Shujaz Inc. We're a network of social ventures. We're based in Nairobi, but we have operations in both Kenya and in Tanzania. Next slide. We believe that this generation of young people can transform global society for the better. So everything that we do at Shujaz Inc. is designed to break down barriers. Next slide. So that young people can take control of the future. Next slide. So just a little bit before we get into the detail of what we do at Shujaz Inc., just to share with you, sort of after 10 years of sustained operations in both Kenya and Tanzania, we reach over 9 million young people in East Africa. That's 71% of all 15 to 24-year-olds in Kenya and 23% in Tanzania. And we reach them through our 3 ventures. Next slide. So we have Shujaz, which is our multimedia youth platform, and that's what I'm going to tell you a little bit more about. Shujaz means heroes. We have the Hustler MBA, our peer-to-peer learning venture, which helps young people upskill for life in the informal sector, and Mesh, which is an online, it's a digital community for entrepreneurs. But today I'm going to talk about Shujaz. Next slide, our multimedia platform that combines large-scale print, that's comic books, social media, no, the slide before, please. Slide 6, thank you. Social media and other digital innovations to reach millions of young people with inspiring content about their financial, their social, and their reproductive health. And then once I've spoken a little bit more about Shujaz, I'll drill down into another creative initiative we designed that really kind of proves the power of authentic storytelling combined with digital platforms to change norms, to build confidence, motivation, and agency, and helps put young people back in control of their lives, their futures, and their reproductive health. Next slide, please. So we have a tried and tested theory of change that Shujaz and all of our initiatives follow. And it starts with great, engaging content that reflects the reality of lives for young people, and that we share across multiple analog and digital platforms. And that these digital platforms, such as we use SMS and social media platforms where young people already find themselves, such as Facebook, Instagram, Twitter, WhatsApp, these platforms are an essential part of the impact delivering to providing safe spaces where our audience, where young people can engage with other people like them and have conversations, and critically, taboo busting conversations, where young people can explore issues that perhaps they might not feel safe doing so in person or in face-to-face. And then also engage with role models on these platforms. Young people, the positive deviants who are already trying the desired behavior, perhaps are already using contraception, perhaps are confident to go to a clinic to access reproductive health services. And by having these conversations, those negative myths and misconceptions that people like me don't do things like this are challenged. And then we know from multiple research studies that we run internally as an organization, but with many academic partners around the world, that when young people start discussing these difficult topics on digital platforms with other people like them in a judgment-free zone, they start to change how they think about themselves. They start to change how they think about these particular issues, and they build agency. Agency starts to develop. And when that does, and they feel more in control of their lives, and they have a stronger sense of their future, this is when they're more likely to adopt the new behaviors. So this is our theory of change, and I'll explain how this has cascaded into some of the different programs that we've designed, interventions that we've designed, but just a little bit on the next few slides about sort of our proven impact. And that it's a critical part of all the work that we do is making sure that we can track the impact that our media campaigns have on the lives of young people. And like I mentioned, we built multiple partnerships with academic institutions such as Tulane University, the University of North Carolina, Cambridge University. And over the years, we've generated some robust evidence of impact. So that we know to date that when people engage with the Shujaz media, the media content that we produce, just go through quite quickly the next 3 slides, they're more likely to delay childbirth, they're more likely to use condoms, and they're less likely to marry in their teens. So our proven ability to shift social norms and deliver behavior change through storytelling had led us a while back in 2010 to be invited by the Population Council, next slide please, and USAID to support their AIDS, Population and Health Integrated Assistance research project known as AFIA2. And our role as Shujaz was to design and produce a multimedia campaign that used the proven theory of change of Shujaz and combined it with digital mHealth tools and create a program for married adolescent girls in Western Kenya. And I'll tell you a little bit about that now. Next slide, please. So at Shujaz Inc., we're led by a simple guiding value that we call player first. And it essentially means that we put our audience first in every decision we make. And it's a bit more than that. It means that we believe that the young people themselves hold the solutions to overcoming the barriers they face. And this is absolutely true for every single family planning intervention that we've made. Young people know why and when they choose to use family planning methods and why they don't. And so that means that we design our programs from the ground up alongside our fans. So when we were invited by the Population Council and USA to create this program for married adolescent girls in Western, the first thing that we did was to go and speak to lots and lots of young women using highly engaging, playful, informal research methods to really understand their experiences and that these experiences, their true stories, informed the drama and ensured the authenticity of everything that we produced in the show. Next slide, please. So in response to this formative research, we created a multi-episode radio drama, a soap opera essentially, produced in the local Luo language, and we called it Chakrok, which means beginnings. My pronunciation is far from perfect. The story that we told focused on the life of a married adolescent girl living in rural Kenya, and it told the stories of her family, her friends, her enemies, and her journey towards achieving her dreams. And this story was told over 24 episodes. The drama explored themes such as early marriage, gender-based violence, contraceptive use, antenatal care, alcoholism, sexuality, and really just told the stories of multiple young people, their families, and the highs and the lows of everyday life. And we accompanied the radio series, which you'll see on the screen here, with some illustrated leaflets and posters. The posters were put up in clinics and pharmacies in the area. And they had the really detailed information, more detailed information on the specific topics that were raised in the radio drama. And 200 community health workers were trained to conduct home visits to reach married adolescent girls, to give them these leaflets and provide them with additional information on reproductive health and on HIV, antenatal care, as well as to make referrals for services when they were requested. Now, the show was so popular that the entire series was repeated 3 more times on 3 different radio stations across Western Kenya, reaching hundreds of thousands of listeners. And it also won a Radio for Peace Building Africa Award in the gender category. I think a critical part of this program design, which we really want to sort of drill down into now, was the interactive digital element that allowed the listeners to discuss the show after each episode. So at the end of the episode, one of the main characters or the actors would say, if you want to know more about the issues, the topics that we've discussed in the show, you can send an SMS to a free short code. You can join in a conversation with other listeners on the Facebook page, or you could tune in directly after the episode, the drama episode, to a live chat that was hosted by a radio presenter and that we had invited sort of medical experts to join in. So some of the questions that we received in response to listen to the radio show would be answered live on air, or were unpacked in more detail on Facebook, and were also you'd be able to get sort of a direct response to your SMS question from an SRH, reproductive health expert. And these conversations that happened live on the radio, they included married adolescent girls, those who were prepared and willing to come and speak, but also local leaders, school principals, parents, people from Ministry of Health, Ministry of Education, all invited to really kind of discuss this issue around married adolescent girls and the challenges they face, and how can we break down the barriers to support them better. Next slide, please. So by setting up these digital channels for continued engagement, we're able to get a real-time feedback from the target audience about what they were experiencing when they listened to the drama show. What additional information or services did they need? What other challenges and barriers were they facing that we hadn't perhaps addressed in the radio drama? And by listening to what they were saying, that by listening to their responses, we're able to adapt our response accordingly to ensure that the live chats address their questions and their needs, that we could bring in the relevant experts, and also produce additional leaflets and posters that would address the most pressing issues. And these digital platforms also generated valuable data that would tell us if the program was having the desired effect. And as we all know, evidence of impact is critical for sustainability, because we need to secure ongoing funding. So a critical partnership for us has been with Cambridge University's Africa Voices Foundation, who've run some really detailed analysis of the SMS messages that we received in response to our media campaigns. So if you just look at the next slide, this is just a slide that shows the number of SMSs that we received about reproductive health from the start of a campaign to the end. So what you'll see here is that at the very beginning of the program, we didn't receive many SMSs about reproductive health. It wasn't a very sexy, exciting topic. And the majority of the messages that we did receive were negative. But as people continue to engage with the program, continue to listen to the stories, we saw the number of SMSs increase, and critically, they became more positive. And with this partnership, this research partnership, if we just ping through the next 4 slides, please, you'll see that we can drill down then into gender and into age, again, allowing us to adapt our programming to ensure that everyone comes on the same journey with us towards behavior change. So almost in summary, next slide, please. I really just wanted to emphasize how important these digital platforms are, enabling us to listen to what our audience is saying. Chak Rock, the radio drama, was extended 3 times, and it also, because it was so successful, transitioned into a news show that ran for several more years. And this is the success and the sustainability of this program, I think, was a result of 3 things. Firstly, evidence. We as Shujaz Inc. need to be able to prove that Chak Rock was generating an impact to secure further funding and support from ministries. Secondly, uptake is just as powerful as evidence. We received thousands of SMSs from married adolescent girls and others in the community. And actually not just us on our direct code, the radio stations were constantly being called to say, we want more of the show, we want more of the leaflets. So without even needing any more funding, the radio shows voluntarily continue to broadcast the show and continue to host live chats with reproductive health experts because their listeners were tuning in their thousands and they wanted more. And I think, and thirdly, it was a result of our being able to adapt to the messages that we're receiving. That was a really key part of the sustainability. What we noticed was that many of the messages that we were getting in response to the show were from girls who were pregnant or had had a baby and they wanted to go back to school, but they were too afraid. And you'll see on the next slide just a couple examples of those messages. And even though there was a government school, or we have, sorry, a government school re-entry policy for girls in Kenya, there was significant social stigma around it. And this was overwhelming, overwhelming for the girls, and they didn't have the confidence to go back to school. So we took this feedback along with the evidence of impact and uptake to the Population Council and to USAID, and together we developed an additional intervention to enhance the access of teen mothers to education. And this is my last slide. So this was the result. So Chak Rock turned, next slide please, into a new drama and a new radio program, building on the year plus of Chak Rock, called Tinyako Malo, which means lift girls up in the local Luo language. And this was building on the learnings and proven impact of Chak Rock, and it focused exclusively on girls who were dropped out of school. And again, our digital platforms were critical to the health and the longevity of this. And ministry participation was also key for this show to be a success long term. In fact, what was really interesting was that the Ministry of Education in Kenya decided to continue to use radio to have conversations about how to support married adolescent girls, and invited the Ministry of Health And I don't know about anyone else, but in Kenya, those two ministries don't often like to collaborate, but they picked up the talk show together to continue to talk to girls of the community members about these issues and others in live call-ins. And I'm really pleased to say that the show did see a marked increase in girls returning to school. And I think just more pertinently now, the Ministry of Health in Kenya has put a new focus on this post-COVID, all informed by the Population Council work with the Ministry of Health that came back from the initial success of Chuck Rock. Just simply a straightforward radio drama telling stories of everyday heroes. Thank you.
Thank you very much, Bridget, for that very insightful presentation on Chuck. Our next presenter, the presentation will be done by two colleagues. That is Kathleen Lehrer, who is a Dicta Health Technical Advisor at IntraHealth International. She specializes in social and behavioral change, e-learning, human-centered design, and communications, which includes, and she's the product manager at mHero, which is the solution that is going to be presented. And her co-presenter is Lois Kurisha. She's the regional systems analyst at IntraHealth International, and she specializes in implementing the technical solutions and software project management. Over to you, Tim, for the presentation.
Thank you. So we can go to the next slide to start our presentation. So to start with, just to give an overview of mHero, it is a two-way mobile phone-based communication system that connects ministries of health and frontline health workers. mHero uses locally popular communication channels to allow ministries of health to send important messages directly to health workers and collect critical information in return. This equips decision makers with real-time information about conditions and needs throughout the country, which enables them to respond appropriately. Additionally, it gives frontline health workers timely information, instruction, and support needed to protect and promote health in their facilities and communities. mHero is a flexible tool that can be adapted to many health communication contexts. Facilitating two-way communication reduces the barriers that can exist between health workers and their support systems, which means that it plays a critical role in ensuring effective and efficient responses, particularly in a crisis, and can have a lasting effect on health systems. mHero was conceived of, built, and deployed at scale in Liberia during the Ebola outbreak. IntraHealth partnered with UNICEF and the Liberian Ministry of Health to develop and rapidly deploy the platform, which helped strengthen Liberia's health sector communication and overall health system, contributing to the end of the outbreak. And then after the end of the Ebola crisis, the Liberian government included mHero as a key tool in the national plan for rebuilding the country's health sector. And it's been included in other national policies, work plans, budgets, and the health information system framework. The full ownership and management of the platform by the Ministry of Health was possible because the Ministry of Health was involved from the early stages of design, development, and deployment of the platform. And the system is continued to be used to this day in Liberia, and there have been several other countries that have deployed the platform more recently initially for the purposes of COVID-19 response. We'll talk a little bit more about the adaptations. Next slide. So during the Ebola outbreak, two-way communication between the Liberian Ministry of Health and frontline health workers was critical for addressing challenges as they arose. With mHero, frontline health workers in Liberia no longer felt cut off from their health leaders, and the ministry had a better situational awareness of what was happening on the ground. Two-way communication is equally important when there is not a health crisis. It provides the Minister of Health with information that guides their response and offers frontline health workers the knowledge, skills, and support they need to deal with the health issues at their facilities or in their communities. The results instill trust in frontline health workers and the government as a whole. So routine communication can be programmed in advance, but it is just as easy to compose and send out one-time messages. mHero permits two-way communication, allowing health workers and health officials to exchange information but it can be also used for communication when there isn't an expectation of a response, one-way messaging. Both the Ministry of Health and health workers can initiate the messaging, and when the Ministry of Health is initiating the messaging, they can send out messages to the entire health workforce, or using information contained in human resources records about the health workers, they can target their messages, which could look like sending messages out to health workers in a specific location or facility who are part of a specific cadre. And while MHERO was initially conceived during the Ebola crisis, it can be used for communication on any topic and for any purpose, demonstrating its adaptability, which is one of the key lessons we're discussing today. And this adaptability is one of the reasons that MHERO has been continuously used in Liberia since it was first launched. Next slide. So to go over how it works, there may be some words and names on the slide that are not quite as familiar, but I'm able to kind of boil it down to a non-technical overview. So the most important thing to know is that MHERO is not a new technology, but it's a new way to connect existing technologies. So it brings together data from existing information systems, which is on the left side of the screen, and locally popular communication channels on the right side to enable targeted real-time communication. And it does this by using global interoperability standards for health information exchange, which are called FHIR, F-H-I-R. So MHERO was initially designed to connect IntraHealth's IRIS, which is a human resources platform. You'll see the solid line on the left side, and UNICEF's RapidPro. So that's the solid line on the right side. IRIS is a package of software for managing health workforce information. IRIS supports ministries of health and other service delivery organizations to track, manage, deploy, and map their health workforce. And RapidPro is a free open source software that allows users to easily build and scale mobile-based communication. Through recent core software development work, we've made MHERO more interoperable and elastic, making it possible to connect other systems and platforms via MHERO. So this could be other FHIR-compliant health information systems and other communication platforms and channels. And this is done through the MHERO connector. And its greater interoperability makes it possible to do more with the platform, such as reaching other types of health workers, such as volunteers or outreach workers who may not be included in the government paid workforce, feeding information submitted by health workers into other health information platforms, such as DHIS2, and sending images, audio clips, and videos, and even sending automated responses through WhatsApp and Facebook Messenger. Next slide. So another step we've taken to set MHERO users up for success and ensure that MHERO will be sustainable is developing a variety of tools and resources to get a strong understanding of the context into which MHERO is being deployed, to build local capacity to manage and use the system, and to set up processes and protocols to anchor the system into the health sector. We have a readiness check to establish factors from the local context that may make deployment easier or more difficult. There are questions about existing Ministry of Health support, availability of staff, availability of technical components, and necessary infrastructure, and availability of resources. The tool assesses where along the continuum countries are in maturity of those factors and components, which helps with determining what is needed to implement MHERO. We've also developed a template to outline the implementation steps, and for each step, the time it will take to complete it, who should be involved, dependencies, and guiding questions and considerations. In addition, we have many documents and tools to provide support with various aspects of implementation, including tip sheets on developing message flows and setting up feedback loops, guidance on cleaning data, and training materials, and more. These materials are all available on the MHERO website, with many of them translated into French. So at this point, I'll hand it over to Lois, who will be talking about our experience in Kenya.
Thank you, Caitlin. So I'm going to take us through the implementation of MHERO in Kenya in our partnership with the Ministry of Health in Kenya. So last year we had minimal information about COVID-19 in the country and in the world at large. And it was necessary to empower healthcare workers with information about the disease, prevention, symptoms, and care, and the need to do it instantly so that we don't have information that is stale. And as information is coming in, we want to be able to communicate to health workers immediately. So health workers, so what we did with the support of USAID last year, we deployed mHero in Kenya. So this involved a partnership between the Ministry of Health in Kenya and the Human Resources for Health Kenya mechanism. So the initial batches of messages was developed from various COVID-19 trainings in collaboration with the Ministry of Health in Kenya. So the messages were refined in collaboration with some divisions of Ministry of Health that you have in Kenya, and some of them is the Division of Community Health. We also have the Department of Health Promotion. We have the Ministry of Health Information, Education, and Communication Material Development Committee, and that was done last year in August 2020. So we really had a lot of collaboration in the Ministry of Health, whereby our messages were approved by the Permanent Secretary for Health in Kenya for dissemination via the mHero platform. So we engaged with county departments of health in 2021 for using mHero as well in specific counties within the country. And we've also had quite a number of trainings for staff from the Ministry of Health so that they can learn how to use mHero and they can be able to send out messages as well as respond to the messages which are coming in through the platform. So one of the good things about mHero is that it is a two-way platform. So you are able to receive messages from mHero and you can respond instantly to those messages. So we had a lot of feedback and appreciation from the healthcare workers. Next slide, please. Yeah, so we had a lot of feedback and appreciation from healthcare workers through this platform. And so this spurred now the development of messages that are targeted to healthcare workers, providing specific services such as reproductive, maternal, neonatal, child, adolescent health, and family planning services. So some of the messages that were developed cover the various themes. For example, we have messages that are covering themes about family planning and reproductive services, from cervical, prostate cancer screening, STI management, infertility, all the way up to reproductive health in the aging population, gender-based violence, child health, and so on. So an example of the messages that we have sent out to health workers include, for example, family planning is a responsibility of both men and women, and it's important for us to promote male involvement. We have a message that we developed that says, emphasize correct, consistent condom use to prevent pregnancy and infection where appropriate. We also had one that said, provide comprehensive reproductive health information to make informed decisions on their sexuality and adhere to client provider rights when offering family planning services. So with these messages that we send out to the health workers who are at the front line, we help them to dispel myths, and we also help them to empower their clients that they are serving so that they can be able to give them the correct information, as well as serving as a reminder. One of the good things that we've seen from mHero is that we get a lot of feedback from healthcare workers who are saying that this platform is so useful to us. It reminds us some of the things that we need to be communicating to our clients and what we need to observe as we are serving our clients. Next slide, please. So far, we have over 80 messages which have been sent out to 25,000 healthcare workers, over 25,000 healthcare workers across the nation. And in total, we have sent out over 2.3 million messages to healthcare workers. In July 2021, we had a stakeholders workshop that was convened to discuss the future of mHero, review new messages on more topics, and train more stakeholders on the platform. One of the things that we have seen throughout our deployment or our use of mHero in Kenya is the excitement that we have from healthcare workers who are not just using the messages for themselves, but also sharing the messages on community WhatsApp groups, and the possibilities of using mHero in the health space are very, very many. And we have a lot of excitement as well from the Ministry of Health, who are actually supporting the system, and the possibilities are endless. So thank you. I will hand it back over to Caitlin.
Thanks, Lois. We are very excited about how quickly mHero was able to be launched and start using it nationwide, very large scale. So it's loved having Lois share the experience there. So just to conclude, mHero, there are a number of ways that we've made it sustainable. So first, by being built into IRIS and integrated into existing health information systems, it is not introducing a new system, and it can connect open source software, which makes it flexible, customizable, and eliminates license fees, although there are still some other costs associated with its use. And being based on global interoperability standards, it can integrate with many other common health information softwares and platforms. Several worldwide networks back the FHIR interoperability standards, and both IRIS and RapidPro have large global communities that are constantly updating and upgrading those platforms. So mHero users will automatically benefit from the continuous software improvements and lessons learned from other implementations. mHero can be used for any kind of communication purpose, any topic initiated by health officials or health workers, two-way exchanges or one-way messaging, etc. And it is easily scalable, as we've seen in Kenya, where there's a national registry of health workers, but it can also be used on a smaller scale for targeted communication to specific groups of health workers, such as certain cadres, specific locations, select contact groups, and more. And lastly, and most importantly, the approach to deploying mHero that we recommend builds in ownership by the Ministry of Health from the start, as demonstrated by the story of launching mHero in Kenya. It can be installed on Ministry of Health servers. Ministry of Health officials determine the customizations. Ministry of Health developers and program implementers are trained throughout the installation and configuration. Ministry of Health officials define the use cases and develop the message flows. And all of this empowers Ministry of Health developers and program implementers to take the lead in launching, managing, and scaling up mHero. So the next slide is just a conclusion with contact information for more information. And please reach out if you're interested in using mHero for your health communication needs. Thank you.
Thank you. Sorry, thank you very much, Caitlin. And we now go for our last presentation, which will be done by Bernard Christopher. He will be presenting on Apojon, previously Mama Bangladesh, under the Mobile Alliance Matan Action. Over to you, Bernard. Bernard, are you on mute?
Hello, thank you. This is Bernard. I'm the Deputy Director of DNet and the Program Manager of Apojon Services. I'm pleased to hear with Apojon stories to showcase overview. And I would like, Apojon is a Bangla word that means the near and dear one in our life. And the Apojon service started in the mHealth journey started in DNet. Please, next slide. Next slide, please. DNET started mHealth in 2010 with Global Health Initiative, and Aponjon launched in 2012. A brief video will describe the project, our workflow, and our impacts. Please, next slide.
Aponjon is an innovative solution using the mobile phone made to make the lives of mothers and babies healthier and safer. This mHealth initiative started under the patronage of Mobile Alliance for Maternal Action, MAMA, funded by USAID and Johnson & Johnson. In 2011, the maternal and infant health scenario of Bangladesh was alarming. One woman died every hour from pregnancy-related complications. 15 infants died every hour for complication within 2 days of birth. Only 1 in 4 mothers had at least 4 antenatal care visits. 1 in 3 mothers had delivery attended by a medically trained person, and 1 in 4 women did not follow exclusive breastfeeding for first 6 months. Aponjon has been working in alignment with MDG and SDG goals to improve the state of maternal and neonatal health since the beginning. Aponjon provides personalized, relevant, and important life-saving information to each subscriber through voice and text messages based on their due date or the age of their baby. It provides 2 messages for expecting and new mothers and 1 message for their guardians every week. The service is also available through web and Aponjon Shogarbha mobile app, available on Google Play and iTunes app stores. The service is unique in its 2-way communication approach. Aponjon not only reaches to its subscribers with health information, but the subscribers can also reach Aponjon from their end. They can reach Aponjon through the call center, which provides necessary support regarding the service, and counseling line, which provides primary medical consultation. All the messages are aligned with week-specific information the mother and her family need at the time. Each message is crafted through state-of-the-art research and validation from national and international bodies, including the government of Bangladesh. Aponjon has launched the first-ever mobile app, Aponjon Shogarbha, in Bangla exclusively for the expecting mothers. Till now, it has successfully reached more than 50,000 mothers' hands. The mobile app helped the pregnant women get weekly health updates. It also has a number of interactive tools that help them get by during these difficult days to reach healthy outcome of pregnancy. Till date, Aponjon has served more than 2 million subscribers with mobile messages and apps. Throughout the years, it has created an enormous impact on the subscribers, helping them improve their behavior and health practices. Aponjon regularly conducts its own impact assessment to evaluate its efficacy. The results of independent researchers also show that Aponjon has a significant effect on knowledge and practices for maternal and newborn health. A study conducted by ICDDRB was able to demonstrate these effects if the subscribers listened to at least 3 messages per month for a duration of 6 months. Since 2011, Aponjon has crossed many hurdles before being widely accepted as one of the world's largest mHealth service. Aponjon has received a number of national and international recognitions. Apunjon's financial sustainability relies on subscription revenue, advertisement revenue, cross-promotion with corporate houses, and CSR support. Apunjon is ready to partner with government, NGOs, private companies, and academic institutions for service and research purposes. Apunjon aspires to bring life-saving health information to every mother's hand in Bangladesh and across the world. Be part of Apunjon's journey and let us build a healthier and happier future generation. Apunjon, power of health in every mother's hand.
Thank you for watching the video. I think the video explains many things about our journey and our achievements. Just to reiterate, here is a snapshot of Apunjon service delivery model. The video highlighted some of the services of Apunjon, but we have expanded our service to include, next slide please. Next slide. A Shogorfa for expecting mothers, Apunjon new mothers, Shoisho for toddlers and preschoolers, Koishors for adolescent and youth. That includes SRH topics and additional to medical support for psychological counseling is also available to these subscribers. In addition to this service, our service model is ready to accommodate any type of content that is appropriate for the clients and the patients. And we have incorporated family planning information and reminders. And these are the contents are served where it is necessary. For example, in Apunjon's Shogorva, that is for the expecting mother, mothers are get reminded about their family planning just before their baby's birth. And after the baby's birth in Apunjon new mother service, just when the babies reach to their second month, and the service is introducing with the family planning issues. And in Apunjon Koishor, adolescents have lots of information, and there are interactive tools to get information as well as the reminder for family planning information and services. Next slide, please. We are very much confident with our contents, and there is a rigorous and continuous improvement of our content, and the contents are evaluated by the global and local health expert to ensure quality and appropriateness of the messages. And for your information, all the Apunjon content is approved by the government of Bangladesh. And we closely work with the ministry to get the appropriate and authentic contents for the specific clients for those information and services. Next slide. Next slide, please. You can see some comparison between national data and Apunjon clients. We can see that Apunjon's clients are more likely to be regular with ANC visits, opting for facility delivery and regular postnatal services. Next slide. Here you can see the customers' perception about Apunjon services. Around 90% responders granted Apunjon as excellent, where 82% responded acquired new knowledge from Apunjon service, and they have expressed that about 83% responder expressed that they are willing to recommend Apunjons to other people. Next slide. Next slide, please. What is the very important thing about the sustainability and to ensure our service benefiting one of the most notable features of Apunjan was that it was always designed to be a sustainable model. The messages were paid value added feature that Apunjan client purchased, and in 2018, after the USAID funding concluded, the project continued to its own. In order to facilitate this transition, we ensured that the tech development was ready so that costs could be reduced. Partnerships were built for content and service sharing, and additional sales channels were created to generate alternative revenue. Next slide. Here is the glimpse of Apunjan partners. Partnership with government facilitated Apunjans to make other partnership and create a nationwide outreach field force. And we have around 14 countrywide and national NGOs in our Apunjan service who are actually engaged with our outreach program, and some of the corporate giants in Bangladesh, as well as the international corporates like Johnson & Johnson. They are partnered with Apunjas for its journey, and we created some valuable impacts. Next slide, please. Next slide. As we are saying that the transition into the sustainable model, the tech solution that we created was schedule and send messaging to the mobile operators automatically. Additional revenue sources are opened by selling aggregator service to various health initiatives and broadcasting campaigns. High cost incurring third-party payment for the call center and the counseling line. We have introduced our own call center and counseling line. And for your information, the platform, both the mobile platform and the call center service, we are being partnered with some other organizations and providing as an aggregated service there. Next slide, please. Next slide, please. As part of the transition plan, Apunjan introduces new services as well as additional service such as mobile application, counseling service, and we also introduce a dialect for the greater client satisfaction. And we also introduced other services as well, as you already said, the adolescent and sexual reproductive health, that is called Apunjan Koishor. And in Koishor, we have introduced three type of counseling service for them. One is for the medical consultation, and in their critical issues during their adolescent period, they can have the option to have psychological counseling through to direct from our call center. And they, in case of there any difficulties to use the mobile application or to have get any support, they can call to our call center customer care service. And additionally, Apunjan also have the ability to adapt with the situation and difficult health issues in Bangladesh. For example, we introduced the awareness content messaging for during the COVID period. And if you say the key features and strength of Apunjan is sending high value content to the clients for the improvement of their health and well-being. While that remains the core of our activities, we have expanded to include more segment, more services, and have improved our service delivery through strong partnership strong content expert pool, and integration on all the telecom operators. And with all these features and service and contents, we have achieved some recognition. Next slide, please. Next slide. And Apunjan received many awards. We have big, with this inspiration, we have some big inspiration. I would like to see some of our future inspiration in the next slide, please. It is our vision for the future. Some of our aspiration includes the incorporation of AI and other new tech to enhance and improve our existing service, to have a physical presence to strengthen the overall health system, and to have national coverage of pertinent health issues so that every Bangladeshi has access to information and service that will ensure good health for themselves and their apunjan, the near and dear one. Thank you from our side.
Thank you, Bernard, for that presentation. We now go to the last segment of the webinar, and I'll be handing over to Tyler Sida. Before I want to introduce Tyler. Tyler is the founder and director of Maternal and Infant Health Consulting. Her work focuses on reproductive health, digital health, nutrition, and community health. And she'll be facilitating the question and answer session. Over to you, Tyler.
Thank you. Colleagues, we are coming to the end of our session. We're delighted to have had the opportunity to co-organize today's event. We've enjoyed partnering with PRB's PACE project, Knowledge Success, and the Medical Concierge Group over the past few months to bring together these incredible speakers to present on 4 global initiatives. We've been continuously monitoring the chat feature for your questions. I've responded to all of your questions either privately or publicly at this time. If you look at the next slide, you will see the information for all of the organizers and presenters. And if you have any additional questions, please feel free to reach out to me and I can redirect them to them, and we can hopefully get any additional questions that you have answered at this time. Well, these 4 presentations have provided you with concrete examples of how digital health can be leveraged to sustain and scale family planning programs. We're excited about how the lessons learned today will contribute to your thinking in the weeks and the years to come. I want to extend a giant thank you to everyone who presented today and everyone working behind the scenes to get those presentations so well put together. I also want to extend a giant thank you to everyone who chose to attend today's webinar. We appreciate your participation. The recording will be shared in English and in French to the hundreds of people who registered and everybody who attended and all of those who presented as well. So you are welcome and encouraged to go back and listen to any pieces of it that you may have missed or pieces of it you want to dive further into. We are at time. So again, I just wanted to thank everyone for a wonderful session and conversation. Thank you, and you'll be receiving an email from us following up. Goodbye.